So, ladies and gentlemen, welcome back after the lunch break. We are back in the sessions, and also this afternoon we have a number of very distinguished speakers, and I'm sure this is going to be a very interesting session here on diagnostic and theranostic concepts for personalized cancer immunotherapy. And it's my pleasure and my special pleasure and honor to welcome Professor Alexander Eggermont, who is chief of the Institute Gustave Roussy, and that is, I believe, the largest cancer hospital in Europe. And he's also a very well-known oncologist, immuno-oncologist, especially in the field of melanoma. And he will give us an update on immune checkpoint blockers drive current revolution in immunotherapy from melanoma across multiple tumor types.
Okay, thank you. So this is where we are in Gustave Roussy, and we have the largest early clinical trial program in cancer in Europe and the largest immunotherapy program. So we put a lot of investments into personalized cancer medicine, and the last 7 years also particularly into immunotherapy. And just for your orientation, that you know where we are, we're in Paris. So taking melanoma as a tumor where the whole immunotherapy revolution has started, there's a number of lessons that we can deduct from the field where we are the furthest into a more transversal multi-tumor approach, and what we may be looking at for the next 10 to 15 years. So when you look at where the cancer immune cycle starts, it's with dying tumor cells. But tumor cells have to die in a particular way to prime the immune system, and for that you need pre-apoptotic autophagy phase that releases a number of factors that actually prime the immune system, so they will pick up the antigens that are going to be released. If you have a non-immunogenic cell death, the immune system is not going to profit from the chemotherapy or targeted therapy that you're utilizing, and then the immunotherapy will not benefit from the other drugs that you're using. However, if you use cyclophosphamide or mitoxantrone or doxorubicin or oxaliplatin, you're using chemotherapeutics, and this is also true for a number of targeted therapies that lead to cell death that help to prime the immune system. These antigens need to be processed, and then they need to be presented, and this happens mostly in the lymph nodes, but it actually even also happens in the tumor, to T cells. So for T cell priming, most of the process is in the lymph nodal system of the body. And a crucial discovery was made here, that because T cells start to express CTLA-4 on their surface to calm down this instruction process. And so they block actually further T cell priming. And this is the starting story of the current immunorevolution. It's with the monoclonal antibody anti-CTLA-4. Then these T cells need to reach the metastatic tumor site, so they need to traffic, and in the end, they need to get inside the metastatic disease, and there they should be able to kill tumor cells at will. They will not only recognize them, but they can also kill them. And here there is a major second blockage system, and that is that T cells express PD-1, tumor cells express PD-L1, and macrophages and another bunch of immune infiltrate cells in metastatic disease also express PD-L1. What happens then? The T cell is completely paralyzed by the interaction between PD-1 and PD-L1, and so this last line of defense is particularly potent. And this is where the largest revolution that has launched the immune revolution has taken place, that you can avoid the shutdown of T cells at the tumor site by anti-PD-1 or anti-PD-L1 antibodies. So, Jim Allison was the one who discovered that in T cell priming, So by an antigen-presenting cell who has picked up the antigen, processed it, and then he presents the peptide to a T cell, that you can prime the T cell and give two signals. There's a co-stimulatory signal here. It drives the T cell into proliferation, and the T cell acquires antigen specificity. So you create an army of T cells to get rid of, let's say, a virus. Now, to get rid of a virus, you may need only this much of an army. So the T cells start to express CTLA-4, and then that binds with this B7 in a competitive fashion with this co-stimulatory binding, and it shuts down the further proliferation of the T cell. So you now have a defined army to use to get rid of your virus. And that's how nature should work, because if you don't have this shutdown mechanism, you would get all sorts of false stimuli, like your own proteins that are being misread, and you would have and we would all be riddled with autoimmune diseases if the immune system would not shut itself down. But for cancer, we need a continuous T cell priming and the formation of different armies that address different antigens, that recognize different clones of the tumors. And so this is what the invention of Jim Allison. By this anti-CTLA-4 antibody, you prevent the shutdown of the T cell priming, and now it just can go on. And that means that you enhance polyclonal T cell priming, and that you will have an anti-cancer effect that you may not have seen before. So the big problem with the immune system in cancer patients is that it's blocked at different levels. I already showed you it's blocked at T cell priming level, but you can unblock it with anti-CTLA-4. It is blocked at the site, the tumor site, for T cell execution function. But you can unblock it with anti-PD-1 or anti-PD-L1 antibodies. Then you must have T cells that can get into the tumor. And we see many tumors that have a ring of T cells around it, but no T cells inside. And this is, for instance, caused by M2 macrophages who create chemokine wall of defense that actually paralyze the T cells that would like to get in, but cannot get in. And we call that immune exclusion. So you can unblock this with M2, M1 repolarizing agents, which are very new agents, but you will hear a lot about it. And then on top of that, you have immune escape mechanisms. Now, some of these immune escape mechanisms are very tough, and when you have those, you're really in trouble, because you can have JAK1/2 mutations at the tumor site, and thereby a loss of gamma interferon pathways, which is what you need for T cell activation. You can have beta-2 microglobulin mutations, and if you have those, not so easy what you can do about it. B-actinin pathway activation, it leads to immune exclusion. T cells cannot get into the tumor. But the first 3 points can be done, can be realized, and are at the basis of the current immunotherapy revolution. So it's all about inhibiting inhibitors. And just think about your own organization or about society or business. People who block or structures that block are far more potent than structures that are actually positive and try to achieve something, right? So you must unblock blockers. So you got to get rid of them. And so the immune system actually teaches us a lesson that this is far more potent than bringing in 10 friends, because the ones who are blocking can still block also your 10 friends. So the crucial molecules are CTLA-4, PD-1, that are expressed on T cells. And so the story is as follows. The central mechanism that I said for T cell priming, to continue T cell priming, you need anti-CTLA-4, and to continue T cell functioning in the periphery at the tumor site, you need anti-PD-1 or anti-PD-L1. So let's start with the first molecule. The first molecule was, like interleukin-2, was developed by Steve Rosenberg at the National Cancer Institute surgery branch, and he actually was the major force in my life to decide what I wanted to do, because I spent 2 years with him. He worked out this trial in patients with metastatic melanoma who already had failed first line, and basically then you have at best 6 months ahead of you. And they were treated with either a vaccine or they were treated with ipilimumab, anti-CTLA-4, with or without a vaccine, the two top lines. And there's 2 observations. First of all, the lines start to diverge after 3 months. So a good stimulation of the immune system needs time to kick in. But secondly, very importantly, once you are beyond 2.5 years, you don't seem to relapse anymore and you seem to be cured. But this is a small 250 patient trial, so let's see if that's true. Well, here, this is 5,000 patients. And you see, it's true. Beyond 3 years, you have a flat curve, and it's around 20% of metastatic melanoma patients. And they are basically cured with only 4 doses of ipilimumab, with 4 doses of not shutting down T-cell priming. And so then you have a variety of T-cell armies that actually cure the patient. There's another anti-CTLA-4 agent, tremelimumab, same observation, also 20% long-term survivors. Here you see the story that the old chemotherapy in melanoma, DTIC, yellow curve, that when you randomize it against the chemo plus ipilimumab, that, yeah, the ipilimumab combo arm does better, but in the end you get the same 20% that you get with ipilimumab alone. And why is that? It's because this kind of chemotherapy doesn't help at all to prime the immune system, because DTIC is a non-immunogenic cell death chemotherapeutic, and therefore it should not be used in combination with immunotherapy. And so these were the first stories. And there was another story. Because if you unblock this shutting down mechanism of T-cell priming, this will happen also elsewhere in the tumor. And so many of us have had some sort of colitis period in our lives, but it was subclinical and it is subdued. It was downregulated. However, it can be now reactivated with anti-CTLA-4. And so colitis is actually a side effect of CTLA-4 that can be serious in 8% and present in 16% of patients. You get T-cell dermatitis. You get hepatitis up into 16%. You may have a pneumonitis. Myocarditis, very, very pernicious, but in less than 1%. But if you have it, it's usually not recognized, and these patients actually die. Pancreatitis, nephritis, neurodegeneratives, you can reactivate a multiple sclerosis, or you can have inflammatory types of radiculitis. And then in the endocrine field, you can get all sorts of stuff. So thyroiditis is the most common, and that's not so, it's not so serious because you can simply treat them with Thyrex, their hypothyroidism. But there is a new disease, it's hypophysitis. It's an inflammation of your pituitary gland. And the pituitary gland is the central axis mechanism of your endocrine system. It's in the sella turcica at the basis of your skull, and it swells up and it gets a compartment syndrome and it dies. So it kills your pituitary gland and you will need multi-hormonal replacement therapy for the rest of your life. Not so good. You can have this in 5% of patients. You can have an acute diabetes that's insulin dependent, which is also an autoimmune diabetes. So not an easy drug, but an incredible discovery that has opened up the gateway to immunotherapy. You will have new types of responses with immunotherapy. These are cutaneous metastases of a melanoma. This is after 3 months. Well, you see, this is a lot bigger than here, right? As you can see, it's progressive disease first. And then it falls into, it shrinks, goes into remission, and it goes into a complete response for the rest of the life of this patient. This patient is actually cured and lives in Los Angeles. Now, the interesting thing is that this is a pseudo-progression because it's not the tumor that has actually increased in size. It's all by lymphocyte infiltration. But we couldn't know that in the beginning, could we? So then all sorts of combinations with ipilimumab have been tried out. But ipilimumab, because it has these toxicities, is a difficult agent. And you cannot make easy combinations, be it with chemotherapies, with cytokines, with other agents. And it's now all out of the window. Why? Because ipilimumab is not the wunderkind. The wunderkind is the next drug. The wunderkind are the anti-PD-1s, anti-PD-L1s. Why? Well, for a number of reasons. The main agents are nivolumab and pembrolizumab, are anti-PD-1 antibodies. And now you look at melanoma, and where ipilimumab had only a 15% response rate, now you see a bigger than 50% response rate with anti-PD-1 that only acts peripherally at the tumor site. The durability of the responses is phenomenal. Once you are a responder, you will have a response, a median of 2 to 3 years, which means that more than 50% actually have long-lasting responses for 4, 5, 6, 10 years, and therefore are cured. And so now you have an agent that has a much more important effect on overall survival, as instructed by this curve. At 3 years, 45%. At 3 years with chemotherapy, the survival is 4%. Now it's 45%. So these are updates, and for this audience, less interesting. So you may have heard about a BRAF inhibitor for a BRAF mutant melanoma, and it gives spectacular responses, but only a very short-lived effect on overall survival. This is chemotherapy, and this is a BRAF inhibitor for a BRAF mutant melanoma. This is the same chemotherapy, and this is the impact of just treating with one monoclonal antibody, anti-PD-1. So that's a completely different world. I skipped those. So what's the message there? The message is that anti-PD-1 has opened up a completely different world because of high response rates and because of very low toxicity rates. So it multiplies the efficacy about 3-fold, and it reduces the side effects 4 to 5-fold compared to ipilimumab. So now you see for the first time with immunotherapy a transversal, transtumoral effect. And whether it's anti-PD-1 or whether it's anti-PD-L1, the effects are the same. They avoid the interaction between PD-1 and PD-L1, and so they avoid the shutdown of T cells. And so the anti-PD-L1s are Atezo and Ave and Durva, but there's many more to come. Actually, the Chinese have 56 different anti-PD-1 and anti-PD-L1 antibodies that are all in various trials in China, but this is only for the in-house market. So what do you see now? You see for the first time with immunotherapy that you see very good response rates in various tumors. This is melanoma, this is non-small cell lung cancer, this is head and neck cancers, this is bladder cancer, could also have been renal cell cancer. This is gastric cancer or esophageal cancer, triple negative breast cancer. Look at this. This is phenomenal. This is Hodgkin that has failed 4 to 5 lines of treatment, including a bone marrow transplant. So these are Hodgkin patients at the end of the road. There's no treatment opportunity anymore. They will die within 6 months. They get anti-PD-1, 86% response rate, 26% complete response rate. Mesothelioma, ovarian cancer, small cell lung cancer, esophageal. So, and this is only the first tumors. There's another panel of rarer tumors where I can say or show similar results. So they were first then tested out in second line after failing first line chemotherapy in many tumors. And so then you see anti-PD-1 against second line chemotherapy in lung. Pembrolizumab against second line chemotherapy in lung. And you see it doubles 1 year and it doubles 2-year survival. It improves survival in renal cell cancer. This is head and neck cancer. I could have shown exactly the same type of curves for bladder cancer and other tumors. So rapidly, anti-PD-1 was approved in multiple tumor types in second-line treatment. But then it goes to first line. And look at this. This is first-line chemotherapy in lung cancer, non-small cell lung cancer. This is the chemotherapy plus pembrolizumab. And the nice thing about first-line chemotherapy in lung cancer is that it's immunogenic cell death chemotherapy. And so you see that in a tumor that has extremely bad prognosis, you see that it basically almost doubles survival at 1 year and at 2 years. So then the question is always, can we predict who are the patients who will respond to immunotherapy? Well, it's sort of logical that that if you have if you have PD-L1 expressing tumor cells, that's your major defense mechanism. And if you then come in with an anti-PD-1 or anti-PD-L1 antibody, you will do much better. So for instance, in melanoma patients, PD-L1 negative patients, PD-L1 positive patients on PD-1, anti-PD-1 pembrolizumab treatment. However, when you look at this curve, this is still better than the curve of treatment with ipilimumab. And it's much, much better than a curve with chemotherapy. So you cannot say you are PD-L1 negative and therefore you will not get anti-PD-1. No, you can only say, well, you're less likely to be a very good responder than if you would have been in case of PD-L1 positivity. And so there's a bunch of factors in melanoma that if there is low sedimentation rate and low T regulatory cells and myeloid depressive myeloid derived suppressor cells in the blood, and you have low all these, then you're a good patient. And if you high absolute lymphocyte count, high eosinophils, you're a good patient, and your likelihood to respond is much better. But if you're not that, you would still benefit greatly from anti-PD-1 compared to any other drug around on the market. And then it's clear that you must have TILs in your tumor. So if you take a biopsy and the tumor is stone cold, there is not a lymphocyte in the tumor, the prognosis is so bad that this is actually the only argument that you can bring to say, well, you're not going to respond to anything. And then you can be a better patient if you have a high mutational tumor burden, neoantigen tumor burden. These are all related, and therefore you will have more T-cell receptors and clonal diversity. These are all related phenomena. And if you have a microsatellite instability, meaning that you have a DNA repair deficiency syndrome, you will have more mutations, and you will create more neoantigens, and you will very likely be a good responder. And you must have an interferon signature if you do an immunogram. So if you have all these, I can tell you, you will have a probability of above 80% to be a very good responder to just anti-PD-1 therapy. Just one single monoclonal antibody with very little side effects. So what is the relationship that I want to get back on? It's been shown for anti-CTLA-4 that if you have more neoantigens, then you are going to be a good responder, and it corresponds to having a bigger mutational burden. It's the same thing for lung cancer patients or any type of tumor with anti-PD-1 treatment. Higher mutational tumor burden, much better prognosis. And it leads to higher neoantigen burden and much better prognosis. It has led to the approval for the first time in the history of cancer medicine that if you have an MSI tumor, that means if you have a DNA repair deficiency syndrome, regardless of the type of tumor that you have, whether it's colorectal or whether it's prostate, if you have this syndrome, you will be a responder to anti-PD-1 more than 60 to 70%. And so there's a FDA approval of anti-PD-1 for any type of tumor in the context of DNA repair deficiency syndrome. This has never ever happened in the history of cancer medicine. And anti-PD-1, therefore, and this is the Hodgkin story for patients who have failed all prior treatments. So this is now the image of anti-PD-1. What has happened in only a short time period of 5, 6 years. So the approvals in 2014-16 are melanoma, renal cell cancer, non-small cell lung cancer, bladder, and head and neck cancer. Then the yellow ones are now, 2018, gastric, triple negative, mesothelioma, small cell lung cancer, and so on. And the light blue ones were the approvals in 2017. And so it's the most important medicine in the history of cancer medicine. Most important drug in the history of cancer medicine. So then everybody wants to do better. And so immune combos now are the next question. So what do you do in terms of immune combos? Well, I explained to you that anti-CTLA-4 had a completely different mechanism than anti-PD-1. And so 1 and 1 could be 3, or 1 and 1 could be 4. And so is that true? Well, let's look at this. Anti-CTLA-4, anti-PD-1 in melanoma. So anti-PD-1 is much, much more potent than anti-CTLA-4. But look, this is the combo. This is the combo for anti-CTLA-4 plus anti-PD-1. Much, much more potent than anti-CTLA-4. But anti-PD-1 alone is already more potent because this is the combination. This is anti-PD-1 and this is anti-CTLA-4 in melanoma. But when you look at overall survival, you see that anti-PD-1 is just phenomenally active and much, much better than anti-CTLA-4. And so then the question is, who should get the combination of anti-CTLA-4 plus anti-PD-1? And this has been sorted out. And in the end, it's only the patients who are PD-L1 negative. Then they benefit from the combination over anti-PD-1 alone. If they have just more expression than PD-L1, than 1%, they will just only need a very harmless antibody, anti-PD-1, and the combination, which is very toxic, it has grade 3-4 events, in 2/3 of the patients is absolutely not needed. Only if you would not respond to anti-PD-1 could you extend with the combination of anti-PD-L1. So ipilimumab alone, anti-CTLA-4 alone is out. And so look at this. Now by reducing the ipilimumab dose, these are metastatic first-line melanoma patients. First-line melanoma patients had a 1-year survival rate of 22% only 7 years ago, and they had a 5-year survival rate of 4% only. And look here, you have a 2-year survival rate of 93%, showing that this is an unparalleled revolution, and this is where I'm going to stop, that puts now immunotherapy at the core of any further strategy in the cancer field. So anti-PD-1 is the molecule that is so strong that whatever we discuss in terms of combination therapy development, be with vaccines, with chemotherapy, with radiation therapy, with targeted therapy, we don't further discuss anymore. The basic core molecule for all these tumors is anti-PD-1. And that's where I want to leave it at. Thank you.
Thank you, Lex, for this very nice presentation. There's a question in the back. Please use your microphone, please.
Hello. Thank you for a wonderful talk. I have 2 questions, one rapid. You never mentioned colorectal cancer in your results.
Yeah. Okay, so colorectal cancer is the big mystery because it does express PD-L1 and it does not respond to anti-PD-1 or anti-PD-L1. So it's an outlier tumor. The only colorectal cancers that respond to anti-PD-1 are the MSI tumors. This is about 5% of colorectal cancers. Response rate is 70% in that case. So the strategy for combos now for colorectal cancer is to look at the liver mets. And so Dirk Jäger and Niels Halema in Heidelberg, they published a paper in Cancer Cell. So most liver mets are do not have T cells inside, they only have a ring of T cells around it. And so they studied these patients, And why are the T cells not getting inside? It's actually a macrophage guided process where the chemokines keep out the T cells and paralyze them and prevent them from coming in. So there is a bunch of drugs now that repolarize these M2 macrophages and M2, M1 macrophages, and then this barrier of chemokines disappears. You see the T cells coming into the liver mets, and with that combination, plus anti-PD-1, you can make liver mets respond to anti-PD-1. So this is going to be a number of tumors who use the same mechanism of defense as colorectal cancers. And that's why I think that the next chapter in immunocombos will be the combination with macrophage repolarizing agents to tackle it not only in colorectal cancer, but in a number of other tumor types. Ovarian cancer could be included, cervical cancer, and a number of others. Yeah.
If I may continue, Mr. Chairman, we had yesterday morning, we had a discussion about immunogenic cell death. How would that come into the play here?
So immunogenic cell death is the combination of chemotherapy or targeted therapies that kill tumor cells. Yeah. And the release of a number of factors that have all been described by Guido Kremer and Laurence Ziedvogel. Yes. Now, if you have those factors being released, you will prime the immune system, and the antigen presentation will be actually serving now a purpose that come and are released by the dying tumor cells because of these chemotherapies or targeted therapies. So we screen at Gustave Roussy all new tumors. For classification, does the new molecule lead to immunogenic cell death or to tolerogenic cell death? And actually, for the companies, it's one of the rationale basics now to make a decision as to which one do you want to develop and which one do you want to develop in combination with anti-PD-1 or other immunotherapeutic strategies.
Thank you very much.
Thanks. I wanted to ask that, so there are anti-PD-1 antibody and anti-PD-L1 antibody. So they both target the same inhibition mechanism. But I wondered how do clinicians choose between these two? I can imagine it's only based on the cost or if it's covered by the insurance. And the other question is, are there data available to compare the outcomes of these two types of antibodies, so anti-PD-1 and anti-PD-L1?
Yeah, so grosso modo at this particular point in time, there do not seem to be, in terms of clinical outcome, big differences between the anti-PD-1 and anti-PD-L1 antibodies. You can have some mechanisms where it may make a difference in some hematologic diseases in particular. Basically, what you're looking at is that you can only hope for more of these drugs coming on the market and that there will be a price war. Because otherwise we will have to have other steps of price regulation to put an end to the current impossible situation. Current situation is ethically and economically not sustainable. So the current situation will lead to a falling apart of the current system because it can kill your hospital budget to just be responsible for anti-PD-1 for lung cancer. So this will be a self-regulatory situation or an intervention by the government.
So Lex, do you think it's all checkpoints that matter, or will there be other drugs also?
So, yeah, there will be other drugs, but the anti-PD-1 is like the prerequisite to make other things work. So anybody who has worked in any type of immunotherapy development program, be it vaccines, which never worked, therapeutic vaccines, never ever, now are being relaunched in the combination with anti-PD-1. Now, vaccines in and by themselves have basically all failed. Therapeutic vaccines. And I remember Harald Zuhausen saying, I can't even imagine how it could work. So, well, looking at the HPV model that once you are infected, it's already too late. So, let alone that once you have a cancer, it would be too late. But now, if you are using anti-CTLA-4 to enrich the T-cell clone programming and diversity of T-cell clones, you will further enhance also toll-like receptor programming, you will enhance vaccines, and so it can be combined because of the very favorable toxicity profile with a multitude of therapeutic approaches. This includes nanoparticles. How about that? But of course, there's many, many programs with now antibodies and BiTEs and all sorts of variations within the antibody world that now will have a second chance to actually be effective.
I think that's a brilliant end. So let's please thank Professor Eggermont again.